Dr. Gupta, welcome to the Block Club Chicago podcast.
Hi, John. Thanks so much for having me.
I'm excited to chat about this because breast cancer, women's health in general, we've made a lot of strides. We've done a lot of good things, but there's still some disparities between outcomes for different groups, and that plays out here in Chicago. So let's tackle all of it, shall we?
That sounds wonderful. Yeah, it's such a emotionally charged topic, right? Because so many of us have had family members, friends, coworkers affected by breast cancer. So I think a lot of us can relate and sort of have an emotional reaction to this topic.
Understandably so. We have, I kind of said it as a throwaway, we have really advanced a ton in our imaging, early detection, and treatment of breast cancer on the whole, right? Let's start with the positives.
Absolutely. I think the big strides in breast cancer screening and breast cancer treatment, like you said, have really affected breast cancer outcomes, right? So, um, what used to be a diagnosis that would just be so devastating 20, 30 years ago, we now tackle it as a very treatable diagnosis. And related to what I do personally, we're so passionate about breast cancer screening, and that's because we know that screening mammography has really reduced mortality of breast cancer by 30 to 40%, which is an incredible number. So that's why we're so passionate about getting women to come get their screening mammograms.
What ages are the guidelines saying now? I know that if you feel something, certainly some examination is important. Just like men with testicular cancer, that's an important step of things. But just generally, if someone's just listening to this and they're wondering, what age should a woman go in for a mammogram?
Yeah, and such a great question because even around that, there's some confusion out there. But we know that most lives are saved when we start screening mammograms beginning at age 40 and continue them once a year, every year, while the woman is in good health, right? So there's no guideline on where to stop. While you're in good health and the life expectancy is greater than 5 years, we know that you would benefit from a screening mammogram. Um, if you go out there and really start digging, you'll find some controversy about do we start at 50? Do we go every year, other year till 50? But again, it is so all of those papers will acknowledge that most lives are saved when we start at 40 and continue every year,
Interesting.
because it is very prevalent in our 40s. Now, some women should start earlier, and we can dig deeper into that when to start earlier. But for average risk women, it's starting at age 40.
The every year thing I think is surprising to me. And maybe this is just because they're different types of cancer. I'm sure that's the case. When I think of colonoscopies, I think of these 5 or 10 year gaps in time.
Mhm.
My limited understanding is that colon cancer is a very slow moving disease. You can correct me if I'm wrong. Is the every year aspect of it that breast cancer is the opposite and that you want to check every year because if you miss a year or two or three, there could be something that's a little more advanced and require a little bit more on the treatment side?
Exactly, right? And we know that certain breast cancers can be fast growing and so some of them are not, but we don't have a magic bullet to tell us which one is not, right?
Hmm.
And so we want to find every breast cancer the earliest we can because we know that when we find it early, breast cancer treatment is most effective and least aggressive. And so that magic number that gives us that most bang is every year.
You mentioned before 40. I imagine what family history, you've noticed some things, or you've maybe obviously had cancer before, even younger, and you're making sure that they're checking every year that it doesn't come back. I mean, those are the people that come earlier, right?
The biggest thing to know is if you have a first degree relative, so a mother, a sister, a daughter with a history of breast cancer, we want to start 10 years before their age of diagnosis. So if your mom had it at 45, we would start at 35. So we want to start 10 years before the age of diagnosis of your first degree relative, but not before the age of 25, right? And then like you referred to healthcare disparities, and we know that in certain women, we even if we start at 40, there are just healthcare disparities. And like in Black women, for example, mortality from breast cancer is 40% higher compared to white women for a variety of reasons, right? So we want to identify women who would benefit from starting earlier. So family history is easy, right? But then there's a whole other variety of factors that play into it. So what we encourage women to do is get what we call a cancer risk assessment. And we can do this as in doctor's offices, primary care, OBs. We do it for at Rush. We do it for every woman who comes in for a screening mammogram or every woman who comes in for a breast ultrasound. And we calculate that woman's personal lifetime risk of breast cancer, right? And if the number we get for your lifetime risk of breast cancer is greater than 20%, then you're considered high risk. And these women need to start screening as early as age 25, and also benefit from more intensive screening. So doing things in addition to a mammogram, we know will be really helpful in finding additional cancers in these groups.
Has the technology and the process of a mammography or a mammogram, sorry, improved? I can remember my mom coming home from getting hers when I was a kid, and this is like 30 years ago, and being like, that effing hurt. That was so hard to do. And maybe it is still that hard and it's still worth it. I don't want to like scare anyone away from
Yeah.
doing something that's that important. Have we improved this at all a little bit? And is it a little more comfortable than it used to be, or is it's still a little thing to do?
I don't want to do false advertising, right? A mammogram is never going to be pleasant, right? It's not, it shouldn't be painful, but we need compression to get good pictures. We've come a long way. We've gone from film screen to digital to tomosynthesis, which is like a 3D mammogram, and we're trying to get these images better and better and faster. So I think we're improving in image quality and cancer detection, but a mammogram's never going to be a walk in the park, right? It
Right,
is.
right.
I it's a few seconds of pain for something really, really important, right? Or a few seconds of discomfort, I would
Discomfort, yeah.
say, for something that's saving lives. So I think that's the bottom line. But I wouldn't tell you, oh, it's easy. It's not. It's not. But it's also, it's better than going to the dentist, right?
Right. There you go. That's a very good point. And yet we do that, well, we should,
But we should.
twice a year. Right,
Right.
exactly. So there you go.
Exactly.
Let's talk about if something is found. I think that's like the biggest fear, of course, as it should be. But as you mentioned, that there is, I think that it's not so much. I mean, cancer in general, we've done so much great work on that with the early detection. I mean, there's still very serious things to go through that can involve some really advanced treatments, but the treatments are there and we're getting better at this. And I guess I say this as a way to like to try and get over people's fears of going to see a doctor in the first place, because this isn't necessarily a death sentence as it used to be.
Cancer is a scary word, right? And I will tell you, some women may not come in because they don't want to know if they have cancer, right? I get that. But as we're talking about it, not only is it that we're saving lives, right? So we know that if a cancer is found in a mammogram, you're 60% better outcomes over 10 years, right? Mortality 60% better in women who had a screen detected cancer versus women who waited till they have a lump. But you'll still hear women say, I don't want to know. I don't want the surgery. But our treatments are getting the smaller the cancer is, the easier the treatment is. We're not talking about removing breasts. That's aggressive, and maybe it's right for some women. It's not right for every woman. And if its cancer is small, we really try to offer lumpectomies where we go in and just, it's an outpatient surgery. You go in the morning, you're home in the afternoon. They remove the piece of breast where the mass was. If it's early enough, it's small enough, you may not need chemotherapy. In some older women with early breast cancer, you may not need radiation therapy. So the key is finding it small. And, I found cancers in 88-year-old women who say, I really don't want surgery. And we really try to tailor the treatment to the woman. But we can't tailor anything if we don't know what's there, right? And when we find it big and large and coming through the skin, then our options are very limited. So the goal of it is to find it early when the treatment is least aggressive, most effective, and even then, everything is done in partnership, in shared decision making with our patients. Our surgeons and our oncologists are so great about that, is finding what's right for the patient.
What are you excited about in the future of this? Because there's breakthroughs, I feel like, all the time, whether it's in discovery and imaging or treatment and beyond.
I think what I'm most excited about is personalization of this field, right? Everything from screening, right? Which women do we screen more intensively? Who needs screening twice a year as opposed to just that generic once a year? Um, and we're getting so good at that. And at Rush, like I said, when you come in and we get all these questions, we tailor our recommendations to your individual risk. So that's step one. Step two is if you do have that breast cancer, how do we tailor the treatment to the patient? Not just of course, what you want, but also to your genetics, to your, what will it respond to the best? So I'll give you an example. So what motivated me to go into this field, when I was a medical student, my mom was diagnosed with breast cancer.
Mm.
And at the time, I really had no idea what breast imaging is. That's what really opened the window of breast imaging to me as sort of the diagnosticians. But the treatment that, in addition to that, so hers was not screen detected. She felt a lump, so it was larger. So she needed the whole 9 yards. She needed the surgery, the chemotherapy. And then at the time, she was put on a trial for what now is the standard of care. It's this drug called Herceptin, which targets these receptors on cancer cells. So some women have them, some women don't. And if you have this cancer, the HER2 receptor, which used to be a poor prognosis, if you had these HER2 receptor cancer cells, that was a bad prognosis of breast cancer. But then we found this drug that selectively attacks this breast cancer receptor with minimal side effects, unlike chemotherapy, which has big side effects, and all of a sudden turned the thing that used to be a negative prognostic factor to a good prognostic
Hmm.
factor because this drug is so effective. And my mom was in the trial for this drug, and we
Wow.
didn't know. We were like, oh, is she going to get the drug? Is she going to get the placebo? Is the drug helpful? Well, they stopped it a year into the trial saying, it's just so overwhelmingly effective that we're going to make it the standard of care. So this is, in the last 20 years that this has happened, and it's happening for more and more receptors that we're finding. And that's so exciting.
I don't want to presume, but did your mom battle through that and make it on the other
Absolutely.
end? Oh, good.
So I mean, let's go down. You're going to walk this walk with me. So my mom did. So that was maybe 15, 17 years ago. And recently, unfortunately, she had a recurrence. So
Oh,
we found another one, but it was on MRI. And because she was high risk, so we did a screening breast MRI. It was 4 millimeters, and all she needed was a surgery. She didn't need to go through chemotherapy again. And so, just in my career and in my lifetime, I've seen such great strides, right? Seeing her find a lump and see the treatment for that versus, oh, it's 4 millimeters. And, not that it's not a big deal, but man, not having chemotherapy was such a blessing for our family, in her 70s.
wow. Yeah, I mean, you've really kind of been through a technological journey through her
Yeah.
advancements as too, as from the trial end of a drug that is now seen as, I don't want to call it a miracle drug, but certainly has been for a lot of people, to why you do these MRIs, why you go back, why you see early imaging. The first time it was a lump, the second time it was an MRI, and the vast difference of that and what those 15 to 17 years mean. Well, I appreciate you sharing that with us.
Yeah.
It's an ongoing journey, of course. I do want to just mention we've exclusively been talking about women, which makes sense, right? It's breast cancer. But I do just want to point out, as I'm always reminded, men get breast cancer too, right?
They do, at a much less frequent rate. So, generally speaking, we don't recommend any screening for males for breast cancer unless you have a known genetic mutation, the BRCA mutation. Um, in which case you would benefit from screening. And then the other sort of nuanced thing I'll talk about is our transgender patients. So male to female transgender patients who have been on hormone therapy for more than 5 years should get screening for breast cancer also. And then the other way around, if you're born female, transitioning to male, but have not had a mastectomy, also need screening mammography.
Okay. You talked about the disparities with this, pointing out black women as well that have, unfortunately, and that plays out in Chicago as well, of course, as we know, less favorable outcomes. we don't have to go into the old genetics of it, but I imagine a big part of this pie is access to affordable health care, regular health care, and encouragement of going to the doctor every single year. All communities struggle with this, but we've seen disparities amongst communities that the chasm is wider. And what can we do to try and turn that around? I know at Rush, you guys try and meet people where they are. Like that is like the biggest thing that I love about what you do is there's you meet people where they are in their communities and you talk the language that they need to hear. Is it more of that? Is it about getting as much people to the doctor for that initial chat that's really going to help out?
That's such a big part of it, right? You hit the nail on the head. I think getting to screening is such an important part of it. And then there's others, right? Then there's the access to treatment. There's molecular genetics of it. We know that that's different in Black women. But what you touched on, just getting detected, if even if you have those molecular genetics, finding it early and finding it small is really what's a game changer. The cancer risk assessment, which I said, some women would benefit from starting earlier than 40. And if you're seeing a primary care provider or an OB-GYN and you ask for it, we can really identify those women who would benefit from starting early. Um, we really are trying to remove as many barriers to screening as we can. So at Rush, we no longer require an order to get a screening mammogram. You can self-schedule a screening mammogram because it's just the standard of care. You can schedule it on my chart, and screening is covered by insurance, right? It's mandated coverage for all insurance carriers. But this year at Rush, we piloted a mammo van to provide screening for women who were uninsured or underinsured, that went out into the community and just, we advertised it. And really the goal was to see women for screening mammograms in this van that was parked out in the community.
Wow.
So we're really trying. It's getting screening mammograms is really the goal.
Yeah. I bet that's so cool, by the way. Did you call it a mammo van? Is that what you
A
said? Okay.
mammo van, yeah,
That's
it's a
good. That's
mammogram machine and a portable van. We staff it with technologists, and then it's read by a radiologist after the exam is done.
amazing. Because here's the other thing too. I imagine that this like spreads in a way. If one woman gets it in an area where less women have, she talks to her friends, right? And then this becomes something that can be a force of change for other people, even though it's maybe one person that got the screening, which is great. And that's so cool. A mammo van. Also, I love the pun. Wonderful. Good work. We talk about improvement of treatments and how things are a lot better. I imagine quality of life after a diagnosis and after treatment is also improved. I've heard from women who fear that they can't maybe breastfeed after breast cancer if they have a child, that pregnancy itself comes with complications. Can you talk a little bit to that just about, and this all probably is all related, right? You catch things earlier, you get things done earlier, it improves the lives of people. I mean, after breast cancer, people often live full, wonderful lives.
Absolutely. I compare it to, because unfortunately, that's part of the job. Part of the job is helping women digest the news of the diagnosis and helping them understand what's to come, right? And I always say it's going to be a tough 6 months, right? I think the first step in treatment is diagnosis. We found it. And the next few months are tough. The diagnosis is tough, surgery, and it's emotionally overwhelming also. But it's not a death sentence. It's a year you'll look back at 10 years from now and you say, you know what? That was a tough year in my life. But it's a bump in the road, right? And again, as long as we find it early and we find it small, we know that it is a curable cancer in its earlier stages.
Well said. Why do you love what you do? I can hear it in your voice. I also hear that
Love
empathy
it.
that is there when you need to be there. And you mentioned that it's part of the job. I never really thought that. Of course, you guys are like obviously psychologists play an important role, but you're kind of like a frontline therapist in some ways doing this. Is that all part of what makes you love what you do?
John, my title is a breast imaging radiologist. I work with 14 other coworkers at Rush, and we all like, if you talk to any of us, we're all equally passionate about our job. It is, you don't go into this field unless you love it, unless you're passionate about it. We believe in the mission, and more importantly, we feel like it's a calling to help women through this time. I mean, and then once they get through the breast cancer and we see them year after year for their annual mammograms, it's just so rewarding. Like we really form a connection, which, going into radiology, that's not what you think. You think you sit in a dark room and you do
Yeah.
studies, but yeah, our field is so special in that way.
Yeah. I've met now urologists, nurses at Rush, talked to you. We've talked to a lot of people. I'm beginning to get and really understand the web that Rush, the net that Rush provides under people that seems to be comprehensive and these departments all communicate with each other in a really well way, which I think a lot of people in other places have experienced just the opposite. And it's a great story that you all tell, and I appreciate it. Is there anything else you want to add to this conversation? Any last thoughts you want for women or men that are listening right now that as a key takeaway?
Okay. I mean, October was Breast Cancer Awareness Month, so everybody was talking about it in October, but I'm so happy we're talking about it in November because this is not a disease that we talk about once a year, right? Just it For women, I would really encourage you to have awareness of what your breast tissue feels like, right? We don't call them self breast exams anymore. We call it sort of knowing what your normal is. And if it doesn't feel normal, if you can keep finding a lump that you're coming back to, please go in and get it checked out. And our goal is to find things before you can ever feel them. So mammogram starting at age 40, once a year, every year.
I love that. That's a good way to end it. It's where we started, and that makes a lot of sense. Dr. Gupta, it was great to meet you, and thanks for sharing. And good luck with your mom, your whole family, and everything. We appreciate it.
John, this was such a pleasure. Thank you so much.